Welcome back, Dr. Ayola, Dr. Ahmed, Mega Pi, and we would like to also introduce to the panel Dr. Ambreen Fatima, who holds an MBBS and a master's in research administration from Harvard Medical School and various other credentials. She previously worked in neurosurgery research, actually, at St. Michael's Hospital in Toronto within the Injury Prevention Research Organization, and she contributed to research on pituitary adenoma. She also serves on the Patient Safety Committee as a patient and family advisor at Lakeridge Health, helping to strengthen safety culture and patient-centered care. She currently works as a senior medical reviewer scientist and clinical intake assessor at a pain management clinic in Canada, where she supports new patients through comprehensive triage and clinical evaluation. So it is my absolute privilege to welcome these guest panelists. Okay, I'll stop sharing now and we can start spotlighting all of the panelists. Okay, so I will be your panel chair for today, and Dr. Zareena Fathah will be the panel moderator. So let's jump into our first question. Initially, we did have Dr. Khan. However, he had a prior commitment, as you all know. So we will be continuing forward with these five panelists. Okay, so first we'll start with Dr. Fatima. Shifting from electrical pathways brings us directly to the absolute bottleneck of translational medicine, which is patient safety. Your expertise lies in clinical research and pharmacovigilance compliance, as you are an expert. So, when treating complex long-term neural conditions like chronic pain management, how do you decide on patient safety to ensure that these neuroscience innovations don't compromise on ethical patient-centered care?
Hi, everyone. So it's good morning here, good afternoon, and good evening to all the people who are here. It's so inspiring to see all your aspiring physicians, future neurosurgeons, specialty taking over and getting up everything. So it's amazingly great. So I just wanted to put up that way. And in terms about the pain management and about like how it has been the ethical values of the AI. We all know we are all getting AI driven. So that doesn't mean that ethics has to be compromised at the chronic pain level. So what happens is like neuroscience and pain management works together. I do see a lot of patients coming in referred by neurosurgeons where patient doesn't feel that they wanted to go through the surgical intervention. So what happens is they come to the pain clinics because see a lot of patients who are unable to work. They are unable to do their work. They are unable to do anything in their lives. So the safety ethics part also is driven that we wanted to make sure that the ethics doesn't compromise with the AI. There are the AI driven tools that helps us with the pain navigations and also about how the pain level is. But at the same time, when it comes to ethics, we do see every person, the patient that comes in, is not AI driven. They do not even understand what AI is. So in a very simple language, I know people have been talking a lot about and about the ethics. Again, there is a lot more work to be done. Though I am in Canada, there's a lot more done for the ethics. It's not just the ethics in Canada. It has to be driven all over the world to get into the ethics. Now, with the pain, patient comes in and they do to let us know. We do get some ethical questions about the opioid risk tool, which is an important tool to do with the risk management as well as to do with the pain. And we need to make them understand that these tools, the opioid risk tools, or the pain scale has to be a part of the evaluation when they comes in for the chronic pain. And the ethics comes involved in a later period of the time. We do send them, and it is a long way driven for the ethics to come into place with the AI driven. Has it been with the ethics for the research? Yes, we have formulated all those things. And there are some tools that if the patient wanted to be anonymous and autonomous, the safety ethics do comes into that place. I hope that was a very late term, and I wanted everybody to understand where the ethics part comes into play. Had I been into a very formal talks, it would have been really hard for you people to navigate. But again, it's very simple. People walk in, they don't come with the language of all those things. It has to be very late term. You have to be very mindful of making them understand that there is ethics involved, there is pain management involved, there are things that are being involved. And there's a very I hope that answers the questions.
Yes, thank you so much for that, Dr. Ambreen. Yes, you completely completely explained that question very well, and I'm sure our audience agrees with that sentiment. So would you be down for a follow-up, Dr. Ambreen? So, for example, when a life-saving neurological drug shows an unexpected or dangerous side effect, but only for a small group of patients, how do experts such as yourself then decide whether to completely pull that drug or to keep it on the market so that it helps the majority of people, even though there are negative side effects for a minority?
What's the very good question. So it's not a very gray and a white and gray answer. It's not just my call. It's just not the clinician's call. It's just not the research calls. Here are the regulatory bodies that are being involved as well. So yes, if there is a marketed drug, and for chronic pain patients, the opioids and corticosteroids are the one that actually takes place. But we cannot put medication on corticosteroid forever because there are side effects as well at the same time. However, if the patient comes in and there are really serious effects like that or any major conditions, yes, those are put onto for future evaluation and risk. However, things are being processed as what is more beneficial as well as to a risk benefit. So if the medication is being turned into life-saving, but there are minimal adverse event, they are being evaluated as a data-driven. And that's how like the AI is automating this, the repetitive tasks, they are just taking that off. But again, at the same time, what happens is like, it's just not one call. It has to be through through a process. Clinicians helps, then as well as the regulatory bodies, the Health Canada, the FDA, and it's not just one. Process takes years and years. We have different regulations. For example, if the research in Canada, we do keep the for 20 years. It's important what generation would be ever just like applies hormone and all, it is not off shelf right away. It's a process that has to be done through an automated data driven and the pharmacovigilance. It's just not one pharma company. It's not just one clinic. It has to come globally, and all the research that's happening all over the world has to be taken into consideration for the risk benefit. But again, not to compromise for serious health effects has to be taken off and carefully taken off the market too.
Okay, thank you so much, Dr. Amreen. We will be now moving to the mind-body biomarker frontier. So, Dr. Ayola now, your research looks at the exact opposite direction of this translation, how the psychiatric states, mood, and anxiety alter someone's physical and cardiovascular state. So, from a research lens, how close are we to using physical biomarkers to actually diagnose and treat hidden psychiatric conditions?
Um, uh, well, it's kind of a half and half answer because at the point that we are right now in history, we are really not close to using just a blood test or a scan to get a full diagnosis. But the strongest approach is multimodal. It's just combining like the brain imaging, EKG, genetics, inflammatory markers, or digital behaviors and clinical symptoms to predict risk, and combine that with the biological responses, like it's a little bit more complex. And the key shift is that we are asking from, does this person meet the criteria for depression or PTSD, more to asking which biological pathways or brain circuits are driving this person's symptoms. So I hope that that's a great reply for your question.
Yes, thank you so much for that insight, Dr. Ayola. So, for a follow-up, what has Harvard's latest data actually taught us about how early childhood psychological trauma, in this case then, could physically change the structure of developing adolescent's brain?
So, Harvard-affiliated childhood adversity data adds an important layer to what I just talked about. So, we know that emotional trauma can create physical changes, physiological changes in the brain. So, the earlier you're exposed to this trauma, the more permanent are going to be these changes to your brain. And these changes, as I was talking in my previous lecture, are part of the triangle of mental health. And it will skew already your predisposition to have such psychological issues. So right now, this is developing, and we're still like researching on it. We know it has an impact. We just haven't researched now how much of an impact it has.
Thank you so much, Dr. Nora, for that again insight. I think it's like a lot more clearer now for all of those who are trying to understand research from that perspective. Also, just a note to the audience. After we go through some of the direct questions to these speakers, we will have a 7-minute segment with Dr. Ahmed. So just if you can prepare just a few questions that you plan on asking her on the chat beforehand when she's speaking. So yeah, that's all I just wanted to tell the audience. And after that, we will have a blitz where we go through live questions, and you will have the opportunity to raise your hand for the other speakers where you can ask them questions live. So just, saying that beforehand so that you guys can prepare meanwhile as well. Okay, so now we will be moving on to Miss Mega. So breathing is something we do every second without thinking, as you were talking about your breath work. Yet we're now seeing increasing neuroscience research that suggests that specific breathing techniques can, change someone's stress, their anxiety, even their brain function and nervous system. So touching on your expertise in breath work and mindfulness, how do you think the science has caught up with what many breathing practitioners have observed for many years? And where do you see this translating into patient care?
Yeah, as you rightly said, of course, these practices have been around for centuries, especially in the yoga and Eastern traditions, alongside meditation and other practices. So currently, I think science is finding more and more agreement. So these practices are moving from something quote unquote good for you, but not very scientifically proven, right? That was code for that. Now it's being more and more integrated into some of the therapies that we offer, right? It is being offered, for instance, something that is not just something that you do on the side, but rather is your first line of action, right? In certain things, certain issues, such as looking at panic disorder, for instance, right? First thing we do is breathe through the panic attack, for example. Now, in terms of research, there is strong evidence, that when your exhalation is longer than your inhalation, so when you extend your exhale, essentially. That leads to high heart rate variability, right? And which in turn activates your parasympathetic nervous system. So science is definitely there. And luckily now we have, means to actually, do research on it. And the endophenotypes that we were talking about previously, right? So definitely science is catching up, and we need to do bigger research. Of course, there is research, but more and more needs to be done, and we need bigger cohorts so that we can, say with complete certainty what we know, as a lived experience, that it's good for us. We can say with complete clinical surety. So there is growing body of evidence, but definitely we need more and more research into breath-based, treatments.
Okay, wow.
Does that answer your...
Sorry.
No, I was saying, does that answer your question?
Yes, thank you so much, Mika. That was very interesting. That completely answers my question. I think you provided excellent insight into the scientific reasoning behind, breath work. So just to follow up, do you have any personal, like, psychological condition or mental health condition that you think personally has the strongest evidence of directly being benefited from breathing techniques in
Yeah,
particular?
so definitely, like mentioned, panic attacks, right? That's our first line of action now. So panic disorders, similarly anxiety based disorders, breathing is definitely integrated into the treatment and treatment plan for patients. And now increasingly for PTSD, it's being introduced as first line of action, alongside other things like progressive muscle relaxation. Before we start to talk about the trauma, we want to relax the nervous system. We want to bring down the stress response. So having a good vagal tone is very important for that. Talking trauma, actually doing the breath work is going to actually land up re-traumatizing the person without giving them the tools to calm that stress response when they feel stressed out, or they have the flashbacks, or yeah.
Okay.
Those
Wow.
are some, but of course, depression and many, many other. There's growing body of evidence, like I said, that breath work can be really integrated into a lot of mental health conditions without the side effects of some of the medications.
Okay, thank you so much. That's incredibly interesting. And I think we've all gained a lot of insight into something that might be otherwise overlooked, when you look into traditional neuroscience. But yeah, that there are lots of, like, scientific evidence behind breath work, and especially for these panic disorders and other conditions like that. And it's very interesting to hear all about it. So now before we move on to the admissions deep dive with Dr. Ahmed, we will be doing a cross question with all of you panelists here. So Elon Musk recently asserted that within the next 3 years, his humanoid robots will be capable of performing complex surgeries with 100% accuracy. So as we see that AI is transforming patient care, do you personally think that artificial intelligence would be an existential threat to future doctors and surgeons or mental health professionals, or do you think we would coexist? And how is AI potentially transforming your field as well? Will it take over? And yeah, we can, just go in turns. Okay, thank you so much, Dr. Ayola. Please continue. You can speak about your opinion now, followed by Dr. Fatima.
So much. I think Dr. Fatima actually had her hand raised before, so if you want to go ahead, Dr. Fatima.
Oh, that's okay. Dr. Rolla, you can go first.
Thank you
I'm so
so
sorry
much
about
for
that.
the time. Well, I love this question because this is the buzz. This is the latest trend. This is what we are talking about. We are just gushing with it. So, AI is just so revolutionary. But remember, like, humans have lived through a lot of revolutions, right? The latest one will be the internet. So when the internet got here, everybody was saying the internet is going to replace physicians, it's going to replace lawyers, it's going to replace psychiatrists. And it that was what it was talked about. We now know that it has become an invaluable tool. We all use the internet. We heavily rely on it, really. And it's going to be the same for AI. It's a great, powerful tool. You need to know how to use it. It's going to be integrated in everything we do. But the thing is that AI has three major challenges. The first one, it will be that it lacks empathy. And empathy is the main driver to understand human suffering, and thus to draw great conclusions to understand another human being. So without empathy, like, it's so hard for AI to actually really assess someone. The second point would be that sometimes AI can work as a mirror or a sounding board. So what you feed to it, it will kind of give it back to you in another format, just because that's what you want to hear. So in the sense that we feed the AI and then we expect it to draw what we already gave it to it. So it can't create, it doesn't have this creative pain in it. It doesn't have the imagination to actually go through new paths. And then the third, and I think this is the most debatable one, but still, like, at this point of time, is the risk assessment. Like, AI doesn't have autonomy, and it can be held accountable. It doesn't have accountability for its decisions. And in mental health, and in neuroscience, and in science in general, you need to have ethics. And AI doesn't have ethics because it doesn't have moral, and it can't take decisions based on this. So you can have it as advice. You can definitely use it as a source to look for new knowledge. It can be like an invaluable tool for research, but for assessment and actually taking decisions, it lacks ethics and accountability. So I think that's my answer for now.
Oh,
Thank you
yeah,
for
thank
the
you so
question.
much.
I love it.
That's very true. I completely agree with everything you said. It does, it lacks autonomy, empathy, and those are some, things that are vital in especially in healthcare professionals in today. And now we will be moving on to Dr. Ambreen's outlook and perspective into this, modern day question.
If you can, are you able to hear me? Okay, so I'll just echo
Yes, we
Dr.
can.
Ayola. So it's the human can lead the AI, but the AI can lead like out there. Yeah, but I can definitely say that those who are using AI, the doctors are using, definitely can replace the doctors who are not using it, because it comes hands in hands, right? So what happens in technology, very late term that I'm going to use it for all the students out here, has a television replace a computer? No, it has its own significance. Has a human interaction replaced a Zoom meeting? No. When we meet together, the empathy, the gestures, the body languages, every makes sense. Similarly, I'll just pinpoint one thing. Patient comes in for a pain, and to Megan's point, what it is, psychological effect. Honestly, when I do some triaging, when I do some patients, my first question is, have you tried physiotherapy? Have you tried massage? Have you tried cognitive therapies? Have you tried mindfulness? If they haven't tried it, we do let them know, because pain is something like an existent thing. Can we touch pain? No. Can our body tell pain? Yes. But how do we do it? On scales. Similarly, AI can help with the data, with the research, great, but not the clinicians, not the ethics, not the empathy. Very simple questions. It can partner with the clinicians, but not lead us.
Yes, that I completely agree. Yes, that's very true. Everything you mentioned, Doctor. And to be honest, I think yeah, I think that while AI is definitely, the future, there are a lot of inhibitions and, things that limitations to it. And yes, I think before Dr. Ahmed, I think Miss Mega will go and explain also her opinion about the AI whole scenario replacing.
Yeah. So I completely agree with everyone. AI definitely can complement, but not replace, at least not in the current form that it exists. Simply because AI does a very good job of mimicking empathy, but very rightly, as it was pointed out, it does not actually feel empathy. It has been designed to please and agree with everything that we say, right? Because it wants us to be engaged with it more and more, for the simple reason that people who are making it are looking at their bottom lines and profits, right? So while that is at the heart of the training that AI has been given, it's going to always aim to please and aim to want to agree, no matter how your information. And in many cases, when things went wrong, they went like fatally wrong, leading where AI agreed to some people to such an extent that it led to psychosis, it led to a lot of mental illnesses, and confirmation of certain psychotic ideas and paranoias. And in many cases, it led to death when it encouraged suicide and glorified suicide as an idea in a mentally ill patient. So definitely it's a very dangerous and slippery slope, so that there have to be guardrails around who is considered as fit for giving therapeutic advice. So as in the current form, it can definitely help as a screening tool. Now, to point out, like, very briefly, the things that it can do well, right? It can screen really well. So AI has been used in many cases to look at, say, the language a person is using, and to identify markers and risk factors for, say, suicidality, right? So things like that, definitely. Screening, yes. As first point of, like sort of just screening, 100%. Maybe even like a passive information giver for people who can't afford therapy, for example, those who are not very, very seriously ill. Definitely, it can, provide, say, CBT exercises to do, provided it's not claiming to be a clinician, claiming to be an expert, and claiming to give advice. So yes, that's where I stand on it currently.
I completely agree. Especially since we have heard, a lot of like cases where, yes, AI did encourage, like drastic measures in mentally ill patients. And we don't probably have the current, guidelines and frameworks for it to completely replace doctors in a way that's safe for patients. Dr. Ahmed, would you like to add your perspective on this, or would you like to move on to your medical admissions segment?
Yeah, I mean, now I can add my perspective. I'm based in the UK, as you know. One of the things that I say, and I hear my students say a lot, is calm down, right? A is here to stay. I don't think it's a hot topic they used to be, because it's so integrated in what we do, from a teaching level, from a clinical level, from an admin perspective. We use it every day. Okay, that's not the issue here. There are limits, but as long as we recognize limits, and I think someone else said that. And one other thing that hasn't been touched on is the bias. In the UK, when we use algorithms and AI, they are on Caucasian populations. They are not on the healthcare groups that are vulnerable. So it widens healthcare inequalities. The other things in interviews, we still use face-to-face online people interviews. I'm still an interviewer. I'm not going to be replaced by AI. So face-to-face is a huge part of our teaching, a huge part of our admissions work. I think medicine, again, I'm sorry, I'm going to give you UK statistics. We have the growing number of people applying for medicine dentistry every year. And that is because it's less AI at risk than other careers. Jobs in tech, in econ, in finance, they're all being taken over by AI, not so much in medicine, right? So that's a really exciting area. We can still grab onto that. The last thing I'm going to say, two very quick points. Some of my patients just come to listen. They don't need AI. They need a human. They need someone whose shoulder to cry on, to listen to them when they feel alone, they feel depressed. They just need that human touch. And the very last point I'm going to make on this is we talk about sympathy, empathy, and compassion. And as doctors, we strive for compassion. Sympathy is the feeling, empathy is looking at someone's, something from someone's perspective. Compassion is what makes us doctors. It means we act on the empathy. So that's what we strive for, and that's why we won't be replaced. That's
Oh,
my
okay. Yeah, I completely agree with that. Yes, bias is definitely absolutely a huge, point. Sorry. You know,
That's amazing. That's an absolutely wonderful answers. All of the panelists, I think he just gave so much perspective, and all of those students out there who might just worry that our jobs might be just taken. I think they can rest in their heart that it could be an ally, but not probably take over. So thank you for your
Can I add a quick addend because AI can't be human.
absolutely.
yes, of course.
Absolutely.
Absolutely, yes.
Awesome. Thank you so much for those thought-provoking insights. I think those insights are awesome. And so relevant. Zara?
Sorry, everything's freezing up for me. Okay, hold on.
I think while Zara sorts her screen out, we will be moving into the admissions deep dive with Dr. Ahmed. And Zara, are you ready?
Okay, I'll just get straight to the questions because
All right.
that's not
Are you?
okay
Are you going ahead?
happening. Yes. Okay, so now we will be
That's not a
moving
problem.
into the admissions deep dive. So to translate these innovations into the next century, we need to look into the educational pipeline, of course, right? So Dr. Ahmed, you have coached hundreds of successful applicants for elite medical programs. So we want to dive deeper into the insider truths that our attendees need to know. So, first of all, given the current competitive landscape, is work experience really that important? Does it set an applicant apart?
Okay, so I've got to get in a sense that not everyone is interested in applying to the UK, and that's fine. As a doctor, we should be flexible and adaptable in our answers. So let me widen a little bit my answer to that. Let's talk about doctor. It doesn't have to be the UK. If you're applying to a career, you need to know what you're getting yourself into. You need to ask yourself, is this what I want to do for the rest of my life? I come from a generation where job was for life. You young people, you're a little bit more flexible. You try something, then you move on. That's fine, right? But medicine requires commitment. It requires resilience. You've got to do at least a 5-year degree in the UK, maybe longer in some other countries, but minimum 5 years. And these are highly academic careers. You need some sort of academic commitment, and you need to be clever, for another term. So work experience is that ticks the box, not only on the application form, also in your interview. You're going to be asked, do you understand what it means to be a doctor? Do you have the characteristics to be a doctor? And like I said, this is broad to any country that you're applying to. So work experience is essential, not only for the application process, but really to answer that question of motivation. Is this what you want to do? So shadow a doctor. If you're applying to the UK, we want you to get NHS experience, and even international students can get that. Lots of free programs, or just come onto my program, okay? But wherever you applying to healthcare in whatever country that you're applying to, make sure you shadow someone, because it is essential to know not only the glamorous side, as well as the challenges that this profession is going to bring. So you really need a really realistic insight into the career. So yes, in answer to your question, it is absolutely essential.
Okay, thank you so much for answering that question. I think a lot of us, now kind of know what the direction we need to go in. We can get work experience, and of course, as international students, we're not in the UK if we're applying to the UK, but we still can get NHS online work experiences virtually and also through programs such as the one you have. So. Thank you for that. Now, another question that kind of links also to international students. What would you say are the biggest kind of difficulties that they face when they're applying?
Yeah, I mean, okay, I'm going to again widen my answer to any application process in any country, so can be relevant to many students. Not knowing the application process is going to be your biggest downfall. So you need to do your homework. Like I said before, you can't be ignorant, right? You can't use that excuse in anywhere, in life or in the application process. So know what exams you need to take. For the UK, it's UCAT. You cannot get around that. You have to do that exam. Know what A-level IB grades that you need. Don't apply if you haven't got the grades. Then you need to know, is there an interview? Do I need to do that interview in person or can I do it online? I have had students who said, oh, I didn't know how to come online. I'm not free then. Sorry, in person, I'm not free. I've got commitments. Well, that's it. Your journey finishes, right? You have to be knowledgeable. And another thing I'm going to talk about is independence. I have dealt with so many mothers in this process. Okay, I don't want to deal with mothers. I want to deal with you guys. This is your application process, right? It's not your mum's, it's not your dad's. I have grandmas, I have uncles. Part of medicine is
I
being
agree.
independent. Yeah, taking ownership, right? So we had UCAT application, lots of mothers trying to log in for their children. No, this is yours, okay? There's a difference between parents helping, kind of lightening the workload, giving a helping hand, and then there's a difference between a parent overtaking. And those students are going to sink and swim. So that's a real red flag. Make sure you take ownership of your own application process, that you are doing the research and you know every single hurdle and barrier that is required for wherever you are applying to, whatever country you're applying to.
Okay, yeah.
I think that's the nationals will struggle. This is very much about, we talked about AI, compassion, empathy, dealing with ethics, telling a person that they have to break bad news. That's part of the role play that we do in UK medical school interviews. And sometimes it's not something like you might have to tell a patient a bad diagnosis, or we've had stations where you tell your best friend that you cheated on them, or you tell your best friend that you've broken their iPad. It can be clinical and non-clinical scenarios. So interviews are the other one, I would say.
Okay, thank you so much, Dr. Ahmed. That was like a burning question that was answered, and I think we definitely have a lot more insight into our admissions now.
I think we can take some live questions and probably any from the chat or
if
anyone
there are
if they want to raise
any live questions.
we will take one by one. So I think shall we start with is there someone who would like to ask a question to her? Or Zara, you could probably just look at the chats if there's no one raising a hand. Have we got anyone raising hands?
I don't think anyone's raising hand for live, guys, just if you want to ask any questions. But okay, let me check the chat box. I think we have a few messages, but I'm not sure if they're questions.
I think we've got
I think there's some sent to
this
the
is to you, my apologies.
No, not at all. Just please continue. Thank you.
So there's a question. Taking psychological science from bench to bedside means giving patients immediate. And if a student is sitting in an exam for a high stress interview and suddenly kind of feels some kind of anxiety or panic, what is like a simple grounding technique that they can use then and there to kind of anchor their mind and interrupt that panic loop? I think this was a student question.
Yes.
And I think we'll go.
Very important, right? And I think it's not just a student question. I use it. In fact, I used it just before I logged in while my camera was off. So, breathing, like I said, making your exhalation longer instantly calms you down, right? So you can, and it's something that you can do it in a very normal situation and nobody would even find out you're doing it, right? So just take a deep breath, hold it for a few seconds, and make your exhalation very, very long, right? As long as you can make it. And you can also do something called box breathing, where you breathe in for 4 counts, hold for 4 counts, breathe out for 4, and hold for 4. And there is also 4, 7, 8. So you breathe in for 4 counts, hold for 7, and breathe out for 8 counts, right? These are just different variable, breathing exercises. You can do them all. You can do one of them, whichever makes you feel calm. So different people would enjoy different ones. Like I enjoy doing breathe in for 4 counts, hold for 4, breathe out for 6, and hold for 2, right? So just see which one feels right for you and use that. Another great grounding technique you can do is 5, 4, 3, 2, 1. I think it's very popular nowadays. So 5 things you can see, 4 things. So we have 5 senses essentially. So you use your 5 senses and then you do 5 things you can see, 4 things you can hear, 3 things you can touch, 2 things you can smell, 1 thing you can taste, or whatever combination of that, right? Basically engaging your 5 senses to anchor yourself in the present moment, right? Worry is nothing but your brain getting stuck on a loop, right? And essentially, it's mostly about things you can't control, right? So, and you cannot get out of anxiety by thinking about it. You have to breathe your way out of it, or you have to anchor yourself into the present moment with your 5 senses.
Yes, for sure. Thank you so much for that, Dr. Nohora. Dr. Nohora, you'd raise your hand, and then Dr. Ambreen will just.
I love your answer, Mega, and I think we need to connect after this because I just love it. Chef kiss. From my end, I love humming because I don't have a singing voice. If not, I will sing. But I love humming because it stimulates my vagus nerve, and that helps me calm down super fast. Or sometimes I do chantings, but like really deep, low, like oh. Of course, when I'm alone, or I'll be marked as crazy person. But humming is the trick for me. I usually just like a quick 1 minute or 2 minutes before something that riles me up, I'll do some humming, and it works for me like a charm.
That's awesome. Dr. Ambreen, would you like to say something like as you raised your hand? Thank you so much, Dr. Nohora.
Absolutely. Awesome. So very late term, I want people to understand where your brain is like a sponge, you fill in what you're thinking about it. You're making it heavy, right? Don't think about it. There are ways. Breathing exercise, great. Singing, great. Whatever makes you happy. But again, at the same time, first of all, thank yourself. Pay gratitude to yourself. What have you done? Have I done anything? No. Did you take a glass of water and drank? Great. You thank yourself. Honestly, these small things, when you started to thank yourself, your brain sends signals to your body. You feel lightheaded. You are really in a calm position. So we're not talking about medical sciences. We're not talking about anything. It's just what you think. Your brain is nothing. It's just a sponge. You're sending signals. So just become aware of yourself. You are worried about your application? I know. I do. I panic a lot. But yes, now I've started to say, how? Will I achieve this? Yes, I will. Will I not achieve it? Yeah. There are certain other ways. There's many things that you can do. It's just not one rooted thing that you have to think about it. So just come and relax, enjoy life. There are certain more other things other than getting into education, your family, your friends, because at one time you are going to be at a position that you want your friends, you want your family, you want yourself. And think about like keeping yourself healthy. What are the new things that you can? Girls can go for cosmetics, boys can go for anything that they want. Yeah, start cleaning up your things, be more relaxed. I hope that answers.
Yes, for sure. Thank you so much. That's awesome. Thank you so much for that. And thank you, Dr. Ahmed. Would you like to add something? And otherwise, we just kind of wrap up the panel.
Sure, I think the ladies have said some wonderful comments. I'm just going to add, the biggest critic is yourself, that inner critic voice. So the first step is awareness. So catch yourself thinking it, otherwise the rest can't follow. So diagnose yourself, watch out for that inner critic voice, and then you can do some of the really practical steps that some of the ladies have spoken about. Now, the only other thing is this takes years because you have been in survival mode for a long period of time. This is your default mode. And to get out of that is going to take practice. So try and, I'm a mindfulness coach, try and do some everyday mindfulness activity. It's like going to the gym, right? You're not suddenly going to get that six pack unless you go in and put the hours. Mindfulness, coming out of that survival mode takes work. And just as we're talking about exams, in life in general, you're going to have to work on yourself to get you out of that negativity and that spiral. But it's, the great thing about mindfulness, and I think someone else touched upon it, is you don't need any extra tools. It's free. Your breath and your body is there. You don't need to go to the gym and get extra, expensive equipment. It's all there. You work with the tools that you were given. It's really powerful, and I would encourage everyone to explore it. Thank you.
Thank you. Thank you so much. Such amazing insights.
Can I add a quick tool? Regarding self-critic, it's so important. And here's a quick tool, everyone. Ask yourself before you talk to yourself, if I were talking to my best friend, would I say these things? And if the answer is no, don't say it. Don't think it.
Fabulous. Thank you for that. Thank you so much, all of you. It has been awesome having all of you on the panel. We really appreciate taking out from your busy schedules, all of that lovely time. And Zara, over to you.
Yes, thank you so much for such a multidimensional panel, bringing together all these different fields and, explaining what the future of medicine is and, how we break down these silos across fields and, how we can link this to our future, our careers, our university options. So we want to now move into our